We have with us Dr. Madhu Kumar, Consultant VR Services, Shankara Eye Hospital, Guntur, and he is going to talk on outer retinal tubulations and subacute hyperreflective material. On to you, Doctor.
Thank you, ma'am, and thank you, Yarsi, for having me here. I'll share my screen now. So, can you see my slides, ma'am, now?
Yes, yes, yes.
Okay. So, good evening, everyone. So, I'll be speaking about the outer retinal tubulations and subretinal hyperreflective material. Just a minute. Okay. So, what's a biomarker? It's a morphological and structural alteration that can provide an important information about the stage of the disease. Now, since the invention of OCT, it has changed the way we look at the retinal diseases by a large means. So OCT biomarkers, especially in AMD, it gives us information regarding the staging, personalizing a treatment depending on that particular eye or the stage of the disease, and following up the patient and to see whether the patient is getting better, that particular eye is getting better or it's getting worse or resistant, and of course to prognosis. So largely OCT biomarkers in AMD, in a neovascular AMD, can be divided into two categories. One is based on the retinal distribution of fluids, that is the intraretinal cystic fluids, that is IRC, subretinal fluids, SRF, or pigment epithelial detachments. Coming to the structural OCT biomarkers, the photoreceptor layer integrity, that is the ELM, EZ, and IZ, the hyperreflective dots, which is already covered, and I'll be speaking about the ORT, that is outer retinal tubulations, and the subretinal hyperreflective materials. So coming to the ORT, the term was coined by Zweifel et al. They are the branching tubular structures which are located in the outer nuclear layer of the retina. And they are circular in or ovoid in shape with a hyperreflective band typically around a hyperreflective core. It's observed in a variety of degenerative diseases of outer retina. First, it was identified in neovascular AMD. It is also seen in atrophic AMDs. And it's just not restricted to the AMDs. It's also seen in the regenerative retinal disorders like an RP, Garrett atrophy, choroideremia, CSR, Stargardt's, and certain diseases. The pathophysiology is not yet completely understood, but it is usually seen in the long-standing retinal degenerative processes. Essentially, it is the rearrangement of the photoreceptor cells and the nuclear cells as a result of a reparative attempt to a retinal degenerative process or in response to an injury. Usually, it is associated with a dysmorphic or an absent RPE. Histologically, it is divided into a nascent, mature, degenerative, and end stage. Essentially, it involves the degeneration of inner and outer segments of the cones. Later, the outer segments lose out, and in the end, only the ELM remains, which is the end stage. Coming to the OCT features, Preti et al. Give an excellent idea of how evolution of outer retinal tubulation happens. So to begin with, we have an RP atrophy and an overlying CNVM or a fibrotic membrane. So over that, the ELM starts falling down. That is, it starts dipping down. So this is the dipping down of ELM, and then it kind of abuts the overlying fibrotic tissue. So this is called an open ORT. Now this large ORT again gets divided into 2 or 3 smaller ORTs. When these smaller ORTs are being formed, the autoplex form layer, that is the OPL subsidence sign, where the OPL dips down between the 2 ORTs, causing the traction on the ganglion cell and the other layers of the retina, inner layers of the retina, which causes small cystoid spaces, which are not fluids, but these are actually because of the traction on the retinal layers. So in the end, the ORT takes its usual feature of a circular hyperreflective layer with the center hyperreflective layer. Now, what are the different forms of ORT? This is essential because when we say ORT, when we interpret an OCT, it doesn't mean that all the time we have to look at the a circular one. So it can be a forming ORT where the ELM dips down. It can be an open ORT where the ends are abutting the fibrovascular tissue, or it is a closed ORT, or an OPL substitution where the OPL layer dips down. And this small microcystic lesion should not be confused with the fluid. This is how it looks in an unfast OCT. It's also seen in, as I mentioned, Best disease, retinitis pigmentosa. You can see here, Stargardt disease. So what literature suggested is overall it is in 30% of the NV cases which are treated with anti-VEGF. At baseline it is 2.5%, and at 4 years it is 41%. So incidence increases despite anti-VEGF treatment, slightly lesser incidence in monthly regime compared to PRN and treat and extend regime. It presents other atrophy as a higher risk. So what Catrial told us was that lower BCVA is seen in patients with ORT compared to those with no ORT. Lower treatment benefits in the eyes with ORT. Eyes with lower BCVA at the baseline tend to develop ORT more rapidly, and it may be considered as an indicator of severity. So Dolz-marco et al. Gave a timeline of how ORT can mature from flat to the typical ORT from 7 months to 17 months. So clinical significance, it has a prognostic value, advanced disruption of the outer retina, its presence suggests poor visual functions. In eyes with neovascularization, the hyporeflective ORT should not be misdiagnosed as an intraretinal subretinal fluid. Its recognition is process separate from exudation, may avoid unnecessary treatment. To summarize, it's a degenerative process. The process in the forms are keen making decisions. Now coming to subretinal hyperreflective material, it's an OCT feature seen as a hyperreflective material located between the neurosensor retina and RP. It is formed of fluid, fibrin, blood, scar, or fibrovascular tissue. It may change with the time or with the treatment. So subretinal hyperreflective material, eyes with SREM have worse visual acuity. If they involve fovea, that eye will be adversely affected. If they are thick and wide, again, those eyes will perform badly because this can appear as a mechanical barrier and damage the overlying photoreceptors. The width affects more than the height because it can prevent the eccentrical fixation. Scar develops more often in eyes with SREM. Anti-VEGF therapy and SREM, significant decrease is seen within 4 weeks of therapy initiation, and it becomes slowly after that. This is because the fluid component is dried up by the anti-VEGF. Later, it is the fibrotic component, which takes more time. Coming to the literature, increased reflectivity and well-defined borders suggestive of fibrotic tissue or mature and neovascular complexes prove that it is towards the fag end, that is it will be a worse prognosis. Associated with IRF or EZ loss, again, it points towards the poor prognosis. SREM clearly distinguished from RP or not doesn't make any difference in the prognosis. Just 1 or 2 cases. Now, this was one thing I want to highlight is no matter how many OCT markers we have or what distinguish we have, nothing can compensate a good clinical examination because it is up to us to decide what investigation it is. So this is a case of PCV. You can see that there's a SREM here, and there is a cystoid spaces and SRF in PED. Octa showed some detectable flow signal in the SREM. FFA and ICGA showed a polyps, but no BVN. The patient underwent intraoral injection of ranibizumab followed by full-fluence PDT. Now the SREM almost comes down with a good response.
1 minute remaining, sir.
Yeah, just 2 more slides. This is second case, another case of PCV. If you see here, there's only SREM, but there is no fluid. So patient underwent Octa. This did not pick up any polyps. Detectable flow was there in the Octa. On an ICG and FA, we did see polyps, but there was no fluid. So we followed up the patient for a couple of weeks. Later, the fluid appeared. And again, the patient underwent intraoral ILIA followed by full-fluence PDT, and it responded. So to conclude, one thing I want to highlight is no matter how many biomarkers or what we have, it just equips us to make decisions and say like, okay, this patient is doing well or this eye is responding to the treatment. And in presence of the ORT or SHRM, it makes us be prepared to explain the patient or to expect that the visual prognosis is not going to be great the moment they appear or when they start consolidating. So they help us in individualizing the treatment, be it from the beginning or to change the treatment subsequently. Decide when to stop aggressive treatment, because we all know how costly affair it is to treat with anti-VEGF treatments. And good clinical examination and multimodal imaging is the key. So future treatment protocols may be based on these markers. Thank you.
Thank you, Madhu sir. I think that was a fantastic talk from your side. Just one question regarding the SHRM. It's a very vague terminology. As we know, it can present as a blood, it can be a scar, it can be a CNVM membrane, or it can be a hard exudates clumps, as you showed. So is there any indication that these are the SHRMs definitely which require to confirm with the OCTA or with the fluorescent angiography, and these are the SHRMs which needs treatment? Any specific characteristic would you like to tell upon?
Yeah, so right now at the present moment, SHRM is it's a vague term. It, as I mentioned, it consists of the fibrin, blood, and all these products put together, and probably a part of the CNVM itself, and it changes its morphology or the consistency with subsequent treatment or the time. So it is essentially, we need to look into it as a changing pattern, and multimodal imaging, as I said, is more important. So just looking at it in an OCT and deciding that
not be possible. Any quick comment from Unni sir?
There is a new, the new international thing on the SHRM has now eliminated the presence of blood from the definition of SHRM. And it is now turning towards SHE, that is SHE, subretinal hyperreflective exudation. So that is one thing. And the second thing is that now the characterization of SHRM itself has gone into something called vascular and avascular SHRM. The indication when you talk about vascular SHRM is that it contains a CNVM component inside. And when you talk about an avascular SHRM, that there is the hyperreflective material, there is no contributory vascular events inside. For this definition, the octa is going to be invaluable. Why this is important is that when there are vascular elements, the possibility of the SHRM persisting and converting into scar tissue is more as compared to when the SHRM is avascular. Now let us bear the fact, like PAM, SHRM is an OCT feature. It is not a clinical disease, and therefore it is not yet, let me say, homogeneous. That is the best term. The definition is not homogeneous yet. Neither is the SHRM. Thank you.